This is Daniel Tobes. I'm presenting a medically interesting case titled, "Should We Even Care About Myasthenia Gravis in the Era of Sugammadex?" This case starts a 51-year-old patient with a history of myasthenia gravis and ulcerative colitis presented to our operative suite for a robotic total colectomy. After a standard induction, he was intubated and paralyzed with rocuronium. The patient proved very difficult to paralyze, as paralytic needed to be redosed multiple times over the first several hours of the surgery. He then subsequently lost all 4 twitches and did not achieve any noticeable recovery over the remainder of the case, which was several hours. At the end, the patient was eventually given Sugammadex for reversal, and he was successfully extubated. This presentation will examine the use of neuromuscular blockers in various neuromuscular conditions and the use of Sugammadex perioperatively in the patient with myasthenia gravis. So if we move on to the lower left portion of the poster, as you can see here, here's a schematic of the motor end plate with our acetylcholine receptors in the postsynaptic cleft, and on the left side is a normal motor end plate, and on the right side you see the destruction of the acetylcholine receptors in the pathology of myasthenia gravis. So this explains why we will see sensitivity to non-depolarizing neuromuscular blockers, because there's a relative paucity of acetylcholine receptors in the postsynaptic cleft of the motor end plate. In these tables here and here, you can see a varying number of neuromuscular diseases and their impact on patient responses to both non-depolarizing neuromuscular blocking agents and depolarizing neuromuscular blocking agents. We'll focus specifically on myasthenia gravis in this presentation. So myasthenia gravis, as you can see, patients tend to be hypersensitive to non-depolarizing neuromuscular blocking agents, and they tend to be resistant to depolarizing neuromuscular blocking agents. The linchpin for all of this is that, in fact, while patients tend to be hypersensitive to non-depolarizing neuromuscular blocking agents such as rocuronium, which was used in this case, it all hinges on whether or not the patient has taken their anticholinesterase medication that morning, as most patients are on long-term therapy with an anticholinesterase such as pyridostigmine. So our patient had taken his morning pyridostigmine dose, which can lead to, by inhibition of the acetylcholinesterase enzyme, can lead to a varied response to non-depolarizing neuromuscular blocking agents, as we saw in this patient, where up front he was relatively resistant to our non-depolarizing agents, and eventually, once we were able to achieve full paralysis, he became hypersensitive, and we had to eventually reverse with Sugammadex. So a proposed mechanism to use, or a pathway to use, in patients with myasthenia gravis for an anesthetic. So ideally, you would want to avoid completely the use of muscle relaxation, as that completely obviates the need for discussion of this problem. So if you're able to perform the surgery with no muscle relaxation, you can either obviously perform a TIVA, you can do a regional anesthetic, or you can do the anesthesia with a general with high-dose volatile agents. If you are required to provide muscle relaxation for surgical conditions, then you need to carefully titrate your steroidal non-depolarizing neuromuscular blocking agents, specifically rocuronium and vecuronium. And typically, patients with MG tend to need only about 10% of the normal dose of non-depolarizing neuromuscular blocking agents. And then at the end of the case, we would recommend that you use Sugammadex to reverse, hence why we would specifically want to use steroidal neuromuscular blocking agents, as they can be reversed with sugammadex. And then obviously before you extubate, you need to verify with your twitch monitor that you have a block reversal, or that you have a train of 4 ratio greater than 0.9 or 90%. Here is a picture of sugammadex, the cyclodextrin that specifically binds the steroidal non-depolarizing neuromuscular blocking agents and renders them inert. So in conclusion, patients with myasthenia gravis tend to be exquisitely sensitive to non-depolarizing neuromuscular blocking agents and exhibit resistance to depolarizing neuromuscular blocking agents. Patients should usually be given their morning dose of anticholinesterase medication, that's pyridostigmine or other medications like it, which can in turn alter their sensitivity to neuromuscular blocking agents, as we saw in this patient. While it's not unreasonable to choose an anesthetic involving muscle relaxation, care should be taken, and neuromuscular blocking agent doses should be carefully titrated. And you should certainly plan on reversing with sugammadex at the end of the surgery to ensure full and adequate muscle paralysis prior to extubation. Thank you.